Hello everyone, thank you for coming to take a look at the preliminary findings of the Health Promoting Schools program. This is a brief overview of the findings to date. We do have data still coming in, and so there will be additional findings to be seen on the website in the months to come. For those of you who aren't familiar with the evaluation that we've been conducting over the years with HPS, a quick overview of what we've been doing. You'll find on the left that evaluation began more formally in 2013, although the program had begun before this. The information that you see in the gray there was considered a formative evaluation. So this was data that was collected from the principals, the students, the facilitators, the site teams, and so on to provide information and feedback to the programmers at the Health Authority and the site teams so that they could do program quality improvement. Later in the evaluation, we started conducting data analyses and collecting data that was related to the summative evaluation. So actually testing what happened in the program, what was effective, and what worked for who. We used what was called a realist approach to the evaluation. So this is looking at what worked for whom and under what conditions, rather than just looking overall, was the program statistically significant in terms of change. You'll see some areas here are starred. These areas with the stars indicate data that was used for our dose response portion of the evaluation. The dose response was an important piece for this preliminary data as we wait for the rest of the data to roll in terms of secondary data. Now, the dose response was based on how concentrated an effort or how concentrated the activity and success that was seen at each school was perceived to be. The dose was based on a variety of values that you can see as expressed by those areas indicated with the stars, where schools who had higher scores across items such as integration, administrative involvement, aligned partnership, activities that were successful, and so on, received a higher dose score than those who did not see high scores in these areas. The reference was made to documents that were presented earlier in the evaluation, as well as to survey collected in self-report form later in the evaluation. So what happened? What are some of the initial findings that we see? Well, to begin with, the priority areas that were chosen were quite distinct and very consistent across the various data sources that we had. Mental health was by far the most common priority area that schools chose to work on, although most schools chose more than one priority area, so mental health often in combination with something else. So what this might look like is something like mental health and physical activity, and the school using something such as yoga to address both. When we start looking at the actual difference between those dose groups that we were talking about and what happened with the Tell Them From Me data. Now, I'll just back up for 1 second. We've been using a secondary data source called the Tell Them From Me survey data that was kindly provided by the school divisions involved in the program. This is self-report student data where the students give answers in relation to their physical health, their mental health, their sense of belonging, and their engagement within their school. Now, for many of the items, there wasn't a difference by dose, but we did see a difference in several areas. One area where we found a significant group difference between those with the high dose on the left and those with the low dose on the right was in relation to total nutrition. So if we looked at all the students who had completed the Tell Them From Me survey scores within the school, those who were in high dose schools tended to see better nutritional outcomes among their students than those in the low dose schools. Now, this was in relation to the amount of sugary or fatty foods that students ate, as well as whether or not they met the Canada Food Guide recommendations. This seems particularly important for girls. So although boys there was a difference, it wasn't statistically significant. Girls it was. So when we looked at girls, we saw that there was a significant difference between those who were in the high dose group on the left and those in the low dose group on the right. for total nutrition. So Canada Food Guide plus sweet and fatty foods considered. Another interesting finding that we see was related to anxiety outcomes. So when we look at anxiety, we see that those in the high dose group tended to have fewer students or a lower percentage of students reporting anxiety-like symptoms than those in the low dose group did. So there was a lower overall percentage of students reporting anxiety-like outcomes or symptoms in those schools that had a higher HPS concentration of activities, partnerships, integration, and so on. Now, this particular variable, while the groups weren't significantly different, we did see that there was a significant correlation. So boys who felt that they had positive relationships with their peers, so that is boys feeling that they had peers who helped them to make healthy life choices, there was a correlation between that score and the score for total dose within the school. So as the dose of HPS went up in schools, so too did the percentage of boys who indicated they had positive relationships within their school. So those are some of the preliminary stats that we see coming out of the data. What about the qualitative findings? What did people actually say? What did they experience? And how were those different between those high dose schools and the low dose schools? So what you'll see here is that we took the qualitative data from a series of sources, so storytelling, document review, interviews and focus groups, and so on. And we coded the data and then split it so that the data that was comments and thoughts by those in the high dose schools were lumped together and those in the low dose schools were lumped together to see were people saying something different whether they were in the high or low dose schools. And there were some differences that we see in the themes coming out. Now, overall, the high dose schools saw more observed outcomes, so actually seeing change or observing change within their school in relation to educational outcomes, mental health outcomes, as well as motivations, beliefs, and values. These positive outcomes tended to be related to student experience. So students saying that it had helped them to grow as an individual, it helped them want to be at school, it helped them feel like they belong within the school. Student engagement was another area where there were a lot of positive outcomes being cited by schools, in particular those high dose schools. Students who were leaders in the program, so those who took a leadership role and were truly engaged within the HPS team, seemed to benefit in their own right. So becoming informed and engaged, acting as leaders within their school had a positive effect not only for their school but for them as individuals. So those are some of the outcomes that we see in terms of what happened at the HPS schools in general, and some specific differences that we see between high and low dose schools. When we start talking about the high dose schools, what actions actually worked or were related to those high dose schools? So when we split the data and the qualitative commentaries by high and low dose, what actions differed? Well, we see within the high dose schools that they often referred to improved physical space. And not just that they use the physical space as an area to improve within their HPS programming, but rather they focused on beautification of the school, creating a sense of belonging within the physical environment, creating spaces that students and families felt connected to and felt ownership over. Versus low-dose schools who often had comments related to the function of spaces, so how the space was laid out, where chairs were situated, that kind of commentary, rather than a space that belonged to the stakeholders themselves. High-dose schools often referred to universal programming, so offering programming that was HPS related or around the HPS priority areas that was open to all students, so no targeting was happening. Even if there was an underlying target group, they weren't overtly targeted, but rather the programming was made accessible to everyone so that there was no stigma attached and it was really part of school culture. Those high-dose schools also referred to planning for sustainability right from the get-go. So while they were planning their activities in their action plans or in their discussions or their other work with the school, right from the beginning they were considering how are we going to make this sustainable, knowing that there was a grant and support that may not be there forever. High-dose schools also had lots of comments related to incentivizing involvement. So this is incentivizing involvement for students to get involved as HPS leaders, but also involved in the programming itself. The incentivizing of involvement sometimes related to actual tangible incentives such as prizes, food, credit for students who are involved as leaders in terms of their volunteer hours, but more often than not in the high-dose group, the incentives were related to students having fun. So really making sure that the health programming was tied into something that they enjoyed. Finally, the high-dose schools had very few comments related to the programming being purely adult-driven, whereas the low-dose schools tended to have more comments related to the program being adult-driven. There were not a huge number of comments in this area, but what comments there were fell within the low-dose group. Now this was an important one I felt, and so it gets a little extra slide here. Conducting a formal needs assessment. So those schools who are in the high dose group often referred to having a needs assessment as the low dose group, but the high dose group said that their needs assessment was very formalized. So they had a survey in place that they did with the students, a process for using secondary data such as the Tell Them From Me survey, or having some sort of formalized interview process where they would call upon students and staff or parents in a very formal manner to find out what was actually needed within the school before doing their planning. The low-dose schools more often had comments related to needs assessment that was very informal in nature. So observing what was happening in the school, having casual conversations in the hall as they walked by folks, and so on. Now these two things seem to be connected often to comments related to the tension for change and existing programming. So tension for change was that if you create programming based around need, people see that need within the programming that's coming down the pipes. So really identifying what folks within the school feel is actually needed will create that movement and momentum to have change. Existing programming within the two groups was slightly different in that the high-dose groups felt that existing programming was something to be aligned with. So they often commented on existing programming being there, but being something that the HPS programming could work with or align to, or that a gap should be filled. Whereas low-dose schools often identified existing programming as something that HPS was in competition with. Now, if we consider the staff and the staff roles involved in HPS between the high and low dose groups, we also see some differences. The health facilitator was identified as a very important role to the program, as was the engagement facilitator. But in particular, the health facilitator, so our health professional who has gone in to work with the schools on their HPS programming, was seen in the high-dose schools to be a person who would inform and educate the school community about health or about resources that were available. They often worked with classroom teachers in an education type capacity within the school. Whereas low-dose health facilitators often had more of a menial role, so doing a lot of material and food preparation and general oversight. Health facilitators at the high-dose schools were often referred to as somebody who had great amount of passion and expertise in this area as well. High-dose schools often made comments about having a student nurse on their team, so having somebody who was doing their pre-service training and practicum portion of their training within the school. Now this added additional man hours to help relieve some of the pressure for actual staff hours. It also provided an extra health-informed staff member to be on site helping out with HPS planning. High-dose schools were also less likely to mention staff turnover. And when I say less likely, this isn't a statistical difference, but rather there were fewer comments, proportionally speaking, in the high-dose group in relation to staff turnover, whereas there were many more comments in the low-dose group. So those are some of the key considerations that people put forward and the key differences between those high and low dose groups thus far. So moving forward, what does this all mean? How does this relate to programming and partnerships as planning for future steps occurs? Now there are 3 areas of data that we will discuss in relation to this. The partner tool, which was a tool that was presented online to organizations who are involved in the program, so the school divisions, the ministries involved, our site teams, and some staff. You'll notice that there are dots or nodes on these graphs that say principal or health facilitator. These folks, individual folks and roles, weren't included in the survey, but rather there were questions asked about them by the organizations involved in the program. Second, we'll look at the Project Steering Committee survey and where that overlaps with this partner tool data, and some qualitative themes that are relevant to moving forward. This graphic is a little bit hard to see, but we'll walk through what it means. So if you look at this web, this is the web that came out of the partner tool. So after each organization was asked questions about what they contributed to the collaboration, where they felt value lied within the program, where they felt stakeholders had influence or power, where trust was, and so on, these are the connections that we see occurring. So the connections that you see here were connections that happened at least once a month. And some of the important clusters that we see happening are the 2 site teams. So if you look in the middle of each of those webs, one near the top in the center and one off to the left closer to the bottom, there's a pink dot with red text beside it. These are the 2 site teams. You'll notice that most of the connections flow through the site teams. What this means is that the site teams are holding together this web. So when we look at the scores for how connected the web was or how dense the web was, you should see a lot of connections between many of the dots for it to be dense. We don't see that here. We see low density. We see that most connections flow through the site teams, meaning if you take the site teams away, the web falls apart. The second thing that we notice is that although most connections are happening to the 2 site teams, their actual scores for centrality and connection were quite low. So they weren't considered to be very high scores, meaning that the relationships that the 2 site teams have with many of these other organizations or dots in the web were not strong enough to withstand time at this point. The other interesting thing that we see is when we ask the other partners about what they see within the site teams, they were reported as being very good at providing resources and information, and they were considered to be very trustworthy. However, when we ask questions about who is the most powerful or influential, the site teams are not considered to be on the list. We see that those who are considered to be most powerful or influential are actually those within the school divisions and school districts. Those with the most power and influence were school districts first, students, principals, and teachers. So while we have all of the connection happening through the site teams, the power and influence is happening outside of them within the education sectors. When we asked about who had the most overall value to this collaboration, the answers were principals, students, school districts, health facilitators, and teachers, followed closely by engagement facilitators and project coordinator. Again, what we see is that although the site team is still the holding the connections for the web, they're also not the most valued portion of the web, nor the most powerful and influential. So how do we create a system where there's greater density and where those with power and influence and overall value are actually those who are keeping the web together? We see similar types of comments coming out in the Project Steering Committee survey, which was conducted. So this is where we asked the members of the actual Health Promoting Schools Project Steering Committee, the administrators and developers of the program across various sectors, to tell us what they thought about the program and what was going on up to this date. All members felt that they saw benefit in the HPS program, but they believed that it was going to be very difficult for schools to implement on their own. They felt that trying to strengthen connections and align goals between organizations was very important. What was very telling here was that when we asked, do you feel that HPS represents the goals of your organization? All the respondents said yes. When we qualitatively asked, what is your goal? The goals were all different. So although there was some overlap in terms of themes about students, the specific goals were very diverse. How do we create alignment between these? Most Project Steering Committee members felt that there was not equal representation between sectors. They felt that there needed to be greater inclusion of the education sector and the First Nations representatives who could contribute to the Project Steering Committee and program as well. So we start looking at programs and partnerships. Some of the things that come out that are quite important in the eyes of the interviewees and across the stories is that the program really needs to be something that's intersectoral. It needs to be co-funded, co-supported, and co-planned. This is also found in reference with the Project Steering Committee and the partner tool as well. Having a common goal and shared language was deemed to be something of great importance. And having opportunities to coordinate and align school partners and have program-supported partners was also seen as beneficial. So to add to this final point there, to coordinate and align school partners meant that although at some schools there were a great number of partners contributing to the schools, and in some cases somebody whose job it was to help organize and strategically decide what partners contribute what and where, how this programming aligned with student health and what gaps were being filled was not always clear. So having some sort of strategic method to align these school partnerships was seen to be beneficial. One suggestion was that the program itself, the HPS program, could oversee some program level partnerships that are common among the schools so that the schools themselves don't have to facilitate that alignment. Some thematic areas that came out that are relevant to moving forward largely related to this higher level administrative involvement. So creating consistency and building trust between the sectors was seen as very important, that what the programming was that health and education together were doing needed to be more long-term, that there couldn't be a continual creating of programming and dropped into schools and then having it pulled back out again. Having unified vision and goal for school health, again, was a consistent comment area. Auditing and alignment of what is available. So not just in terms of partnerships, as we mentioned in the previous slide, but within health, health departments themselves can be quite siloed and have a variety of services. So having an audit of what the health sector itself is providing to schools would be very beneficial. And then aligning those together so that they are not so siloed, but rather co-informative and providing a unified service to schools may be helpful. Education, again, could provide alignment in terms of what partners they have and aligning those partnerships to the needs that they've identified in their needs assessment. It's important to understand that this type of programming in the Health Promoting Schools approach, or the comprehensive school health approach, is not meant to be about addition. It's not about adding on additional clubs and things unless that's what's needed. It's supposed to be about integration. So integrating health philosophies and a health lens into the school culture. One example of this is classrooms. There are many comments and quotes within the qualitative data that indicated that one area where this type of integration could happen would be to help inform teachers as to how to blend a health lens into their classroom rather than adding on additional tasks for teachers. How do you blend health into the lessons that they're already required to teach? Having a dedicated HPF staff member was considered key. So having somebody whose hours and job it is to address this type of work was considered fundamental to program success. Part of this, though, were the many comments that were related to rethinking the health facilitator role. When we say rethink the health facilitator role, this meant a variety of things to a variety of people, but by and large it meant having a role that's not split between multiple and conflicting job descriptions, but rather having somebody whose designated role it is to work with schools. Having them close to the school and linking their school work to their clinical work was considered to be a good suggestion. And having dedicated and protected hours as well as informed co-workers was also seen as helpful. Principals were really viewed as gatekeepers to the success of this program. So although the engagement facilitators were intended to be the gatekeeper to the program within the school, principals really seemed to create the tone by which the program grew around. So principals who were supportive of the idea set a positive tone for other staff and for movement within the program, rather than a principal who was unsure or opposing the program, where the tone could be quite difficult to work with. This was also related to educator wellness and readiness. So are teachers themselves informed about this type of program, the impact that this type of program has on student health, the links between health and learning outcomes, and their own professional training and ability to incorporate this into their classes and understand why it should be incorporated within the school. Connecting to universities was one step that was deemed to be potentially helpful. Addressing pre-service teacher and nurse training was one suggestion where universities could help to contribute to the success of this type of program. So if pre-service teachers and pre-service nurses learn about comprehensive school health or health promoting schools approach, then we have a common message among these professionals across schools. So it would help to mediate things like staff turnover and help with things like integrating within classrooms. Now, the overarching theme that we see here really relates to the necessity for those movers, shakers, and policymakers to get involved. So this was built as a grassroots approach and was meant to be such. But at this point, the grass has grown and needs that support from above, the sunshine and the rain, for the program to continue to grow from the grassroots up. Meaning there needs to be a system approach with concrete, defined, and aligned policies and partnerships between the health and education sectors with those common goals, common language, and shared vision that we spoke about earlier. One interviewee said, "We have individual trust and communication, but system-level trust and communication isn't there. Just because person 1 from education and person 2 from health know each other, one cannot rely on personal trust alone. There needs to be trust in the process and vision for it to work. It's a multi-dimensional trust." And finally, I felt this quote really summed up much of what was said in terms of unifying the effort behind these items like comprehensive school health between sectors, and where the health and education sector can work together to really conquer some of the major goals that they're each facing and work on them as a unified force. This person said, "It's a rock analogy again. Push the right rock up the hill, not 20 little rocks. Get bigger barriers out of the way. But you need more people, fewer part-time people, and more heavy lifters to move that rock. Maybe we are choosing the wrong rock to push up the hill, or maybe too many little rocks over and over again. Maybe we choose one big rock and work together in unison. Thank you for listening. I look forward to presenting the upcoming evaluation data for you later.